Hello, my name is Tamas Szakmany, the Associate Editor for Social Media at Critical Care Explorations. Here are my top reads from Critical Care Explorations this month. Ordering a diagnostic test and acting on the results of those tests is the cornerstone of critical care practice. When a diagnostic test could be influenced by several factors, including underlying acute disease, this interpretation and appropriate action becomes difficult. Dr. Garcia and colleagues investigated the use of troponin I and the subsequent therapeutic changes made by critical care providers in sepsis patients in a large observational cohort. In their study over 82,000 patients, they found that patients who had a high initial troponin results underwent more investigations and were more likely to be treated with beta blockers and anticoagulants. However, the practice was diverse and did not seem to follow evidence-based recommendations. Their work is an important information for designing future interventional trials for adoption and de-adoption of diagnostic strategies in sepsis. Retained guide wire following a central line insertion is a rare and serious complication which can be classified as a never event by several healthcare systems. Dr. Cassis and colleagues analyzed data from a large academic institution and found that over an 8-year period, 24 of these events happened. Interestingly, the majority of these procedures were performed by experienced clinicians in non-emergency scenarios during normal working hours. Their findings should serve as a reminder that our intuitive beliefs can betray even the most experienced operator. Emphasizing data-driven procedural steps to ensure safety of the patients should be the norm for all critical care practitioners. Hospitals with a significant burden of safety net, who have lots of Medicaid and uninsured patients, have worse outcomes across several medical and surgical conditions due to resource constraints and more advanced disease presentation. In a retrospective observational study, Olani Pekun and colleagues investigated if this phenomenon can be associated to in-hospital cardiac arrest survival as well. They found that in over 500,000 patients who suffered in-hospital cardiac arrest over a decade, those patients who were treated in a high safety net burden center had a significantly lower chance for survival. They also observed that increasing median household income was associated with better outcomes. The results highlight an urgent need for research to evidence-based policies to tackle these inequalities. Please take time to read these articles and more by visiting ccejournal.org.